So our next topic is pneumonia. Pneumonia is basically a lung infection of the lower respiratory tract or lungs is known as pneumonia. Pneumonia can be bacterial, they can be viral, they can be fungal. Bacterial pneumonia are by far the most common type of pneumonias, and about 80% of the cases of community acquired pneumonia are due to Streptococcus pneumonia, which is also known as pneumococcus. And we all know that a vaccine to pneumococcus is available. So the most common cause of pneumonia is Streptococcus pneumonia. And the most common cause of pneumonia in COPD patient or acute exacerbation of COPD is Haemophilus influenza. And the most common organism that is separated or that can cause infection in bronchiectasis patient, that is also Haemophilus influenza. So remember these points about the different bacteria. They are important. So the most common cause of community acquired pneumonia is Streptococcus pneumonia. Streptococcus pneumonia, the other point for Streptococcus pneumonia is that it is associated with herpes labialis. Herpetic lesions, if someone is presented to you with signs of pneumonia, signs and symptoms of pneumonia, and he is having herpes labialis as well, that is herpetic lesions around the lips, and they ask you about the causative organism, then you will select Streptococcus pneumonia. So herpes labialis associated with Streptococcus pneumonia. And a person with COPD developed pneumonia and they ask you about the most likely organism, your answer will be Haemophilus influenza. Similarly, in case of bronchiectasis, most likely organism will be Haemophilus influenza. So if someone developed pneumonia after influenza infection and they ask you about the causative organism, then your answer will be Staphylococcus aureus, because it can cause pneumonia after influenza infection. Mycoplasma pneumonia, Legionella pneumophila, Klebsiella pneumonia, Pneumocystis jirovecii. What are the differentiating points for them? Remember that Mycoplasma pneumonia and Legionella pneumophilia, both of them cause atypical pneumonias. What are atypical pneumonias? Atypical pneumonias are pneumonias which does not have typical signs and symptoms of pneumonia, that is productive cough. Atypical pneumonia usually present with dry cough. So Mycoplasma and Legionella pneumophilia, both of them will cause dry cough because they are the cause of atypical pneumonias. And also the chest X-ray findings will also be not typical. Chest X-ray finding in case of typical pneumonia such as pneumonia due to Streptococcus pneumonia, there will be lobar consolidation. There will be consolidation of one lobe, complete lobe of the lung in case of typical pneumonia. While in atypical pneumonia, the chest X-ray findings are also atypical. For both Mycoplasma pneumonia and Legionella pneumophilia, both of them causes bilateral patchy consolidation and not lobar consolidation. Patches of the lungs are affected in Mycoplasma pneumonia and Legionella pneumophilia. Both of them causes atypical pneumonia. So signs and symptoms will also be atypical, such as dry cough, and X-ray findings or investigation findings will also be atypical, that is patchy consolidation, and that too bilateral patchy consolidation, and not just a single lobe of the lung will be affected, but there will be bilateral patchy consolidation. Klebsiella pneumonia, it causes pneumonia in alcoholics and in diabetics. In immunocompromised patient, it usually causes pneumonia. Pneumocystis jirovecii pneumonia, it is generally seen in patient with HIV. It also presents with a dry cough. So Mycoplasma, Legionella pneumophilia, and Pneumocystis cerevisiae. All of them can cause pneumonia that present with a dry cough. Then how you are going to differentiate between Pneumocystis cerevisiae and other? Remember that Pneumocystis cerevisiae is seen in patient with HIV when their CD4 count is less than 200. So a patient with HIV has a CD4 count of less than 200, and he present to you with dry cough. Or another specific feature for Pneumocystis cerevisiae pneumonia is uh, the person get short of breath on exercise or on exertion, is oxygen saturation drop. So dropping of oxygen saturation in an HIV patient is a diagnostic feature of Pneumocystis cerevisiae pneumonia or Plab 1. So these are the different organisms that can cause pneumonia. Idiopathic interstitial pneumonia is basically non-infective cause of pneumonia.
Excuse me, doctor, I have one question.
Yes,
Plasma legionella during the bilateral patchy shadows, right? In X-ray.
yes.
What about Klebsiella?
In Klebsiella usually first point for Klebsiella is that it affects the older people, alcoholics and diabetics, and second is that it affect the upper lobes commonly. It cause cavitating lesions in the upper lobes. So cavitating lesion, if it's given in the options, then you will think of Klebsiella pneumonia.
Okay.
While Mycoplasma and Legionella, they affect the basal lobes. So there will be basal patchy consolidation.
Okay, doctor. Another thing like upper lip cavitation,
Yes,
and diabetes. It can also be seen in tuberculosis, right?
yes. In tuberculosis, there will be history of travel to Africa. There will be
Mm-hmm.
weight loss, and also if there is no history of travel to Africa, the patient will have a history of HIV.
Mm-hmm. Okay. Understand.
So these are the risk factors that should be present in case of tuberculosis. That is history of travel to Africa, night sweats, weight loss, typical features of TB will be given in the
Okay.
history or in the sign and symptoms. In history of HIV and CD4 count of uh, less than 200. Remember that Pneumocystis cerevisiae pneumonia is also common if CD4 count is less than 200, and tuberculosis is also common if CD4 count is less than 200. The differentiating features for both of them is that if a patient present to you with productive cough and his CD4 count is less than 200, then it is most likely tuberculosis, along with cervical lymphadenopathy and other features of TB. And if the person is HIV, his CD4 count is less than 200, and he present to you with dry cough and exertional dyspnea or exercise induced desaturation, then it will favor Pneumocystis cerevisiae.
Okay. Okay.
And if the person with HIV has a CD4 count of more than 200 and he present to you with productive cough, then it will be streptococcus pneumonia. So normal CD4 count and pneumonia feature in HIV patient, it will be streptococcus pneumonia. And CD4 count less than 200, it can either be Pneumocystis cerevisiae or it can be TB. If it's dry cough and exercise induced desaturation, then it will be Pneumocystis cerevisiae. If it's productive cough and typical features of pneumonia, then it will be streptococcus pneumonia. Idiopathic interstitial pneumonia, any condition that can cause a lung fibrosis, they are included in idiopathic interstitial pneumonia because it is idiopathic, so the cause of this fibrosis is not known. Community pneumonia can be community acquired or it can be hospital acquired. If the person develop pneumonia in the hospital, it will be known as hospital acquired pneumonia, and if the person develop pneumonia in the community, it will be known as community acquired pneumonia or CAP. To differentiate between community and hospital acquired pneumonia is important because the antibiotic uh, first line antibiotics are also different for community acquired and hospital acquired pneumonia. So what are the symptoms of uh, pneumonia? Typical pneumonia, that is fever, cough, sputum, and dyspnea, and there may be chest pain, that is pleuritic. So an infection of the lung can cause these symptoms. What are the signs of pneumonia? Fever and tachycardia due to infection, reduced oxygen saturation. On auscultation, as there is consolidation, so breath sound will be reduced and there will be bronchial breathing, not vesicular breathing. How we are going to assess a patient with pneumonia? If we are in primary care setting, we will assess the patient by CRB 65 score, and in secondary care, we'll assess the patient with CURB 65 score. So in secondary care, because testing facilities are available, so in secondary care setting, we'll use CURB 65 score that include urea as well. While in primary care setting, because testing facilities are not available, so urea will not be included in uh, CRB 65 criteria. C for confusion, so 1 point for confusion. R is for respiratory rate. If respiratory rate is more than 30, 1 point. If blood pressure is less than 90, systolic blood pressure less than 90, 1 point. And if age is 65 years, then again 1 point. So we'll score the patient on the basis of these four criteria in a primary care setting. If the score is zero, then it's a low risk and he can be managed it at home with antibiotics. If score is 1 or 2, it will be intermediate risk. And if score is 3 or 4, then it is high risk. CRP can sometimes be used also to guide antibiotic therapy. If CRP is less than 30, no antibiotic is needed. If it's between 20 to 100, then a delayed antibiotic prescription can be given. And if CRP is more than 100, then we'll offer the antibiotic therapy at the spot. So you need to remember the CURB 65 score and the management on the basis of CURB 65 score that we calculate in secondary care setting. A CURB 65 score of 0 or 1 are low risk patient and they can be managed at home, while CURB score of 2 or more than 2, they should be managed in the hospitals. And a CURB score of 3 or more than 3, they should be managed in ICU, high dependency units. Investigation that are done in case of pneumonia is chest X-ray, and for intermediate and high risk patient, blood and sputum culture and pneumococcal and Legionella urinary antigen tests are also done. Now, what is the management of pneumonia? First of all, we are going to discuss hospital acquired pneumonia. The management of hospital acquired pneumonia is different from community acquired pneumonia. So the first choice of oral antibiotic, if the person has developed hospital acquired pneumonia, is co-amoxicillin, that is augmentin. And if the person is allergic to co-amoxicillin or penicillin, then we'll use doxycycline in patients who are 18 years or above, and clarithromycin in patients who are less than 18 years of age. Cotrimoxazole can also be used. So for hospital acquired pneumonia, if mild symptoms or non-severe symptoms then we'll use comoxiclav. And if there is allergy to penicillin, then we'll use doxycycline or cotrimoxazole in adults. And in children, a doxycycline is contraindicated, so we'll use clarithromycin. And in case of hospital-acquired pneumonia, because in hospital-acquired pneumonia, serious, severe signs and symptoms are present. For example, signs of sepsis are present. Then we need to give piperacillin with tazobactam, ceftazidime, ceftriaxone, or cefuroxime. Then we need to give IV antibiotics. And if we are suspecting MRSA infection in hospital-acquired pneumonias, then we will add vancomycin or teicoplanin as well. So this was management of hospital-acquired pneumonia. Now, management of community-acquired pneumonia, again, if low severity symptoms are present, or if the patient is, yes?
Just can you go up a bit? Just I want to note that down.
Severe symptoms, IV antibiotics. If mild symptoms, then oral antibiotics. Comoxiclav, doxycycline, or clarithromycin, or even cotrimoxazole as well.
Thank you, doctor.
So the treatment of community-acquired pneumonia for low symptoms or for low risk patient whose GERB score is 1, 0, or 1, we use amoxicillin. If person is allergic to penicillin, then doxycycline, clarithromycin, same choices as in hospital-acquired pneumonia. And if the patient is pregnant, then we'll use erythromycin. So amoxicillin is the first choice in pregnancy. And if a person is allergic to amoxicillin, then we'll use erythromycin and not doxycycline or erythromycin because they're contraindicated in pregnancy. The only mycin that is safe in pregnancy is erythromycin. And if the severity is high, GERB 65 score is 3 or 3 to 5, then we'll use comoxiclav with clarithromycin. So single drug, if GERB 65 score is 1 or 2, and two drugs if the GERB 65 score is 3 to 5, that is comoxiclav and clarithromycin. Levofloxacin can also be used in high severity patient for penicillin allergy. Remember that if a child, what we are going to do in children, if the children are under 1 month, then we'll refer them to pediatric specialist, and we'll only treat the children who are 1 month and above. And the first choice antibiotic in children as well is amoxicillin, and the second is clarithromycin. Clarithromycin is used in children